It does really take an entire team to help manage these patients because they are so complex. I think that's what makes it fun. And it's what also makes it really challenging too, though.
Hi everyone, welcome back to PedScript. I'm Zach Hodges, a pediatric critical care fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
Today we're excited to be back for part 2 of our discussion with Dr. Ali McMichael and Dr. Lisa Settle on pediatric ECMO and specifically managing anticoagulation.
Yes, we are so excited to keep talking with Ali and Lisa about ECMO anticoagulation, especially because Ali is the first author of the 2021 ELSO Adult and Pediatric Anticoagulation Guidelines. Let's get right to the episode.
I think it might be helpful to kind of look at each individual lab test that we get to monitor anticoagulation and review maybe when it's less appropriate to use, if there's something that maybe makes it unreliable. Maybe we'll start with anti-10A and when you're managing a patient on heparin. What are the major limitations there?
Sure. So the anti-factor 10A is our measure of heparin effect. And so it really tells you how much heparin is in the system, in the body. It's a chromogenic test for most centers, which means it's affected by color change. That's how the test works. And so anything that affects color is actually going to affect the test. So we tend to see that in the form of hyperbilirubinemia. So high bilirubin, high triglycerides, and high plasma-free hemoglobin will all affect the test results. And those are really important because oftentimes, especially in our neonates, right, we have high bilirubin, and then as we are going along in our ECMO run, we tend to have hemolysis, and so the plasma-free hemoglobin may rise as well.
And I think at our center, we refer to that test as the unfractionated heparin level. Does that sound right to you?
Yes, that should be the same level. Some people call it an anti-10A, some people call it an anti-factor 10A, but in the lab itself, it may show up as an unfractionated level.
So there are obviously many other tests. We mentioned the PTT that we'll use for all of these anticoagulants. How do you choose a goal range for APTT?
So really controversial question, actually. So most people would say a goal PTT range is 60 to 80. And that's all based off of adult data. So when we actually look at neonates and peds, their goal PTT at baseline is actually higher than our adults. And so most people will either say 60 to 80 or 1.5 to 2.5 times their baseline. And so if you're lucky enough to catch a patient prior to going on ECMO, a lot of us will figure out what their quote unquote baseline PTT was, and then titrate my PTT for 1.5 and 2.5 times that baseline if it's elevated.
Because this number may be elevated, their clotting was normal when healthy, and now we're just looking at how much we augment.
Correct.
Yeah. So at a lot of places, they're also doing an ACT or an activated clotting time hourly because it's almost a point of care test and sort of measures the clot formation in whole blood. How are you interpreting that value in this setting?
So I think ACTs are really helpful as a trend, especially since most places tend to get them every hour, every 2 hours. And like you mentioned, Alice, they're great because you can do them at the bedside. You use a small amount of blood, you get results immediately. And so I think it's a nice trend to have, especially if we see a significant increase or decrease, then I want to know what's going on with the patient. Important things to know about the ACT is there can be some inter-rater variability within the test itself. It's also affected by platelets and hemodilution, which we can see pretty frequently, especially when we're going on ECMO. And so that's just important to know when you're getting these tests, is just try to think about it in the context of what's going on in the patient. But I think as a trend, the ACT is a helpful test. And one thing that we didn't mention is that, there's 2 types of tests when we're thinking about ECMO anticoagulation. We have our whole blood tests, and then we have our plasma-based tests. So ACT is a whole blood test versus PTT, which is a plasma-based test, as technically you would think about anti-10A as well. Our other whole blood tests would be our viscoelastic assays like TEG or ROTEM. And so these are kind of the new cool testing on the market for ECMO anticoagulation. And the reason for that is TEGs or ROTEMs give you what we think is a complete picture of a clot. So we get idea of clot formation and then fibrinolysis or clot breakdown. The tests are not available at every center and they are expensive, so that's some of the disadvantages of them. But the advantage is you get to have an idea of function. So not only are you getting an idea idea of platelet quantity, but actually quality. How well your platelets actually working? How well is your fibrinogen working? How well are your factors working together? So to see how strong our clot is or not strong our clot is from the test. But one of the disadvantages that we have right now is we actually don't have a lot of data to support their use. And so the at least research right now doesn't support significantly that it improves clinical outcomes. There's a few studies that are starting to hint at that, but I think we need more data to really decide if we're going to move completely over from our current testing to just using VHAs or viscoelastic assays.
I think tags are so neat, and definitely wasn't something that I used prior to fellowship. It's a complex test. It tells you lots of information. There's lots of different variables that are measured. What specifically are you looking at on the tag to give you an idea of how well your patient's anticoagulated?
So the main thing that I look at is the R time. So that gives me an idea of how much heparin that we have in the system. And then the rest of the test I look at is trying to figure out how well my patient's able to form a clot. So I want to get an idea of what their angle is, what their MA is, and then how quickly they're breaking that clot down. And the reason I care about that is that doesn't necessarily, I'm not going to be titrating my heparin up and down based off of my angle or my MA, but it does give me a sense of, I think this patient is at higher risk of having a bleed because I'm worried about their platelet function. And so even if their platelet count is 60, for example, and my goal was 50, I may say, actually, you know what, I think we need to increase our transfusion goal to 75 or 80 because really this MA is very low, and then I may be concerned about patient bleeding. That's, I think, what the overall hope and goal is for VHAs, is we'll really be able to titrate and tailor our not only heparin titration, but also our transfusions of platelets and fibrinogen based off of the assay. Whether or not that actually is going to improve patient outcomes is still yet to be determined.
Yeah, I think TEGs are a really cool opportunity here because I just being at bedside and after seeing us give so many transfusions of different types of products to patients who have very abnormal coagulation markers, we often get fluid overload. And then we're in a situation of now I'm trying to diurese my patient and we're starting Lasix strips and I'm also still transfusing. And how do I balance this in order to actually get them to a place where they're able to come off of ECMO? So I'm hoping that with us becoming more familiar with the use of TEGs, that we're able to be more intentional with the blood products that we're giving our patients.
Oh yeah, to be a steward. I've been really frustrated at the bedside. I have to say this because I grew up interested in critical care. You know, we've got podcasts, articles, people writing about the power of the TEG, and then I'm on call and it's 2 a.m. and at our hospital, you can only run it from 9 to 5 on weekdays. And you've got this like precious life in front of you where you think that a TEG could really help and it's unavailable. So I do have to mention that.
And I think that's the hard thing, is that we are continuing to get more and more tests and fancy things, but it's not available everywhere and all the time. And it's actually an interesting test to run, but it is a little bit complex. And so you have to have a really knowledgeable lab technician to be able to run the test as well. Otherwise you can get significant variability. So I definitely hear that, Alice, where sometimes I think, you know what, this tag that we ran at 4 a.m. is a little bit different than the tag that we ran at 4 p.m. And I wonder if this is just technique and we need to run this again.
The TEG professional can't be working literally 24 hours a day.
Yeah.
We talked a lot about how these lab tests can be discrepant and maybe it's hard to know what you need to believe and what steps you need to take next. Let's think about our case. That neonate on VA ECMO, septic perhaps, the PTT is really high, the 10A is really low, maybe the TEG is cooking. Walk me through your thoughts about how you would go about evaluating that patient and trying to decide if they need more anticoagulation, if they need less anticoagulation, or if they're fine to stay right there.
I think that's great. I mean, this is the thing that we have all the time at 4 a.m. and it's totally the scenario as well, that the TEG is still cooking. So we don't have the third test to help us decide which of the other two we're going to believe. And so I have questions, actually, more than answers right now to try to figure this out. So one of the things I would want to know is, what was the neonate's baseline PTT? Was their baseline PTT actually a little bit higher? And 90 is actually not too far from what our goal actually is for PTT. The other thing I'd want to know is are there any factor deficiencies? And that's where the TEG actually may be helpful. So remember, when we run a TEG, we run a TEG normally and then a TEG with heparinase. So you take away all the heparin. And so then that gives us an idea of what's going on in the patient themselves if they didn't have any heparin in their system. And so you can look at the R time and see if it's significantly prolonged. And then that actually may be helpful to let you know there truly is a factor deficiency. You can definitely send factors. So I would think about sending like a factor 9 or factor 8. But honestly, at least at my previous institutions, this would take days to come back and wouldn't be helpful in the, at the bedside currently. Also, fibrinogen may affect your PTT. So you would, want to be looking for a fibrinogen deficiency as well.
And that would be a low fibrinogen would make it higher?
Yes, a low fibrinogen.
Make it higher.
So we tend to think about hyperfibrinogenemia as actually decreasing. So our patients who are super inflamed who are on ECMO, so you think about like patients we saw this a lot with our patients who had EVOLI for some reason, just very overall inflamed, had shortened PTTs their entire run. And then when you're thinking about a low anti-factor 10A, I want to know what's going on with the antithrombin level. So is our antithrombin level actually 20? Then our anti-factor 10A level may be low because we don't have enough AT3 in the system. And so what you may be seeing with a low anti-factor 10A and a high PTT is that you have not enough heparin in the system and a factor deficiency in the patient. And so neither of those things are good, right? We want to give more heparin so we don't cause a circuit to clot, but we also want to treat that factor deficiency so that we don't have the patient be at increased risk for bleeding. And so sometimes what can be really confusing is I may actually transfuse FFP and go up on heparin for this patient. And, this may be an instance where a TEG actually may be helpful to give you more information about those things and help you decide, do you really need to give FFP and go up on heparin at the same time? And then the other thing I forgot to mention as well is, are there things that are affecting the 10A test, making it falsely low? And so I'd want to look at the triglyceride level in the patient, the bilirubin, and also the plasma-free hemoglobin, because those can all falsely lower your 10A.
So maybe this is a hard question to answer, but do you have a line where you would say, this bilirubin's too high, these triglycerides are too high, this plasma-free hemoglobin's too high, I can't rely on the 10A? I'm sure it's a continuum, but where do you draw the line?
So we tend to think about a bilirubin greater than 6, so a total bilirubin greater than 6, triglyceride level greater than 500, and then a plasma-free hemoglobin greater than 50. Some centers will use 80. And so you think about, that's actually not that high of a plasma-free hemoglobin. Like we often see numbers in the 50 to 100 range, especially on longer runs. And for a lot of our neonates, especially in their first couple of days of life, they're going to have a bilirubin greater than 6. And so that's when it can be difficult to interpret our anti-factor 10A.
So during the first year of my fellowship, I think that the most anxious and confused about a patient at the bedside I've been is anticoagulation in ECMO. In one sort of type of scenario, you've got a patient who's on, they're on heparin per bleeding protocol or bivalve per bleeding protocol, and they are hemorrhaging just onto the bed, not brain, not life-threatening, but just hemorrhaging onto the bed. You've activated matches of transfusion protocol multiple times. They may or may not have known fibrin on their cannula. They may or may not have like a known IVC clot somewhere. And I feel like it's just so hard to know when you need to stop pouring blood in and just stop your anticoagulation completely, or if that is more harm than good. And so I'd love to hear your perspective, understanding that these scenarios are rare and that you don't have like a large cohort study on it.
Yeah, I think that's a scenario that all of us struggle at the bedside. And this is something that we talked about, both for creating the ELSO anticoagulation guidelines. I've also been part of our PEACE consensus, which is a group of ECMO anticoagulation experts who've been trying to form recommendations and guidelines regarding ECMO anticoagulation. And this is a really hotly debated topic of when to stop anticoagulation and for how long and what you should be looking for and really what the risks are. And I think the honest truth is no one really knows what's safe. We've started to continue to push our boundaries of, both what types of patients we put on. We're starting to put even more sick patients on, and then what we're willing to do while they're on. And so, for example, when I started, we very rarely put patients on who had malignancies and definitely not bone marrow transplants. And now we've across the country have seen patients who have survived with those things. Same thing for trauma. We used to not put patients on with massive traumatic bleeding because we thought they would just bleed on ECMO. And there's been some success, at least in the adult literature, of running heparinless circuits. So I think some of that decision of when to stop anticoagulation actually really depends on the size of your cannula and then how fast you can run your flow. And so for a very small 8 French arterial cannula on a baby who's only flowing 80 to 100, that makes me more nervous to stop heparin than on a very large 23 or 25 French arterial cannula that you have in an adult. I'm much less worried about stopping heparin in them. But in a patient that you know that is continuing to hemorrhage and requiring MTP, besides replacing all of the blood products, you also want to know, is there anything surgically you can do? Is there any obvious area that you can go after to try to repair? And there's also some really great topical products as well that you can try. Some centers will also use antifibrinolytics like Amicar as well to try to help. And sometimes you can run them concurrently with heparin as well, just to try to help increase a little bit of clot formation, keep that clot a little bit more stable.
We talked a lot about the role of lab tests for monitoring anticoagulation, but how much do you use your eyes? Like how much do you use the bleeding that you see and then maybe the fibrin deposition or the clot formation in the circuit to perhaps maybe break a tie? Is that too imprecise to use clinically?
I don't think so. I think the hard thing for a lot of medicine is we want to protocolize it. We want to try to standardize what we're doing and have a global idea of this is going to be our heparin protocol for all patients, and we're going to go up and down by this percentage based off of these labs. And I think the hard part with ECMO and anticoagulation is that every patient is different. And so we talked a lot about this neonate on ECMO, but if you think about a neonate who's on for meconium aspiration is very different than a teenager with, for example, leukemia with fungal disease who's on for ARDS and sepsis. Right there, just baseline underlying coagulation system is going to be very different, partly based off of age and partly based off of their critical illness and everything else going on. So I think we can't use necessarily a general protocol for all of our patients. We oftentimes do have to tailor our therapies and our transfusion goals to the patient themselves. And so not only are you thinking about the individual patient and what's going on behind the scenes, why did they go on an ECMO in the first place, but I think you're right, Zach, you want to look at the bedside too and say, okay, this patient who's going to be on for 3 days, who's not septic, who has no clot burden, I'm probably okay running them on the lower side of my PTT goal. But this patient who's on their third circuit, who has, significant clot burden, fibrin straining everywhere, who has an IVC clot, this patient we're going to run on the higher side. And so I think that's one of the really frustrating but also really great things about anticoagulation is you really do have to tailor it, in my mind, to the patient. And so I think that's why the testing can be really frustrating as well, but often it's helpful to have 2 types of tests. And so just going back to thinking about our tests as a whole, I think about running a whole blood test and a plasma-based test. So 2 tests that I can have an idea of how much heparin do I have in the system? And so I think about an anti-10A for that. And then what is my patient's risk of bleeding and clotting? And so oftentimes I'm looking at either a PTT or a TEG to answer those questions. And then you look at the patient themselves and then try to figure out, okay, what's going on in the patient? What is their risk of clotting and bleeding? Does that help? Does that answer a little bit?
Yeah, it's just a complex answer for a complex question, right? The patients that we put on ECMO, they're not healthy. They're not thriving. And I think it's just requires us to be at the bedside and give it our full attention.
Zach, I think when we started as fellows, we were in our first ECMO runs and these neonates and teenagers, we were scared a little bit and we are told to follow this protocol and, there's all of these steps to follow, but really getting kind of that comfort. And the first question I always ask before I make a change is to the ECMO specialist, how does your circuit look? How comfortable are you with the clots that are building up? Are they progressing? Are they better? And just kind of knowing that it's okay to deviate away from that protocol a little bit if you're using good clinical judgment.
That's a great point. I think ECMO is a team sport. So not only do you have your bedside nursing staff, but you have your ECMO specialist or perfusionist, depending on your center. And then you have your intensivists. Sometimes you even may have a hematologist or a transfusion medicine specialist and a surgeon as well. And so it does really take an entire team to help manage these patients because they are so complex. I think that's what makes it fun. And it's what also makes it really challenging too, though.
It's a lab puzzle.
That's right.
Yeah. So where do you see the field going in terms of next steps? What research needs to happen to really define and refine these anticoagulation guidelines?
Yeah, so I kind of break that down into, I think, 3 things. So testing agents, and then technology. I think we're going to continue to have more research come out about different types of testing, especially viscoelastic assays. Like Lisa's project, trying to see if we can figure out what is the goal R time for a neonate on ECMO. And so I think hopefully we'll have more and more data that VHAs really are helpful. And I think the next thing we talked about is, are we going to find a superior anticoagulant to heparin? And are DTIs really the answer? Or is there a new drug that's even better that we haven't even heard of yet that we can use? But honestly, I think probably the most exciting, or what may change how we anticoagulate patients the most, is going to be technology. So, there's definitely been improvements in the ECMO circuit technology and the cannula technology, but I'm curious to see if in 10, 20, 30 years, we have a completely different ECMO circuit and completely different ECMO tubing, right? And we didn't talk about this, but the whole reason that we have to anticoagulate patients on ECMO is because as your patient blood is leaving the body and going through this ECMO circuit, it recognizes that this circuit is foreign. These are not my normal vessels, and starts forming clots. But what if we had a new circuit that actually the body didn't recognize as foreign? Then that may completely eliminate, or at least significantly decrease, the amount of anticoagulation that we'll need to use. So I'm really interested to see what new technological advancements we come with. And maybe in 20 years, we'll just say, heparin, what was heparin? We don't even have to use this anymore for ECMO. Yeah. What were all these crazy tests that you guys all sent? So I'm excited to see where ECMO goes. I think, like I said, it's a relatively new technology compared to some of the other things that we have. And so I still think we have a ton to learn. And hopefully you guys will be able to tell me about it later.
Yeah, that's right.
Yes.
ECMO does seem like something that has potential to significantly change over the course of just our career. So it's exciting to know about this next steps. As we wrap things up, anything else you want to cover today? Maybe anything to plug about where our listeners can go to learn more about ECMO anticoagulation?
So we do have the ELSO anticoagulation guidelines that are out. I think those are a helpful resource to start. The ELSO Red Book as well is a nice resource, not only for anticoagulation, but just ECMO in general. And so I would encourage you to bother one of your attendings to use that book. I think that's a nice resource as well. You can also go to the ELSO website. And so there's a lot of guidelines and protocols on there as well, which I think is a nice resource.
That's perfect. And then for your final question, what are the key points or maybe the takeaways that you'd want our listeners to take from this? Maybe Lisa, if you want to get things started.
Yeah, I think just as a new fellow stepping into this, and even like still now as I'm learning and seeing more ECMO at the bedside, just as you're getting these discrepant labs back and you're trying to figure out what's really going on in my patient, just to take a second and really think through, what's my patient on ECMO for? What does my circuit look like? Where have my labs been? Where are they going? Kind of looking at that trend and just taking a second to make that decision on how you're going to make a change to heparin or even switching to a different agent. I think a lot of times people look to us in the moment at 4 a.m. and they want a quick decision, and that's not always an impulsive decision that we want to make. And so I think it's important to recognize that you have time, or at least time to make a good decision about any changes you want to make.
I think what Lisa said is great. I mean, really thinking about what's going on with the patient themselves and what their risks are for bleeding and clotting. And then I think understanding what your tests are measuring and what are the limitations of that test can really help. Because I think the biggest frustration that we hear from our bedside staff and from our team is, I have these two labs, just like this case, I have these two labs and they don't correlate. Which one am I supposed to follow? And when they don't correlate, that's not always a bad thing. It just means they're measuring different things. And so we need to figure out why one is lower than the other, or higher than the other. And once you can understand what the test measures and then maybe why it is high or low, if it's affected by something within the patient, then I think it becomes a little bit easier to try to figure out what to do next.
Well, thanks so much. Thanks so much for being here with us today and delving into this really tricky topic that is maybe so much dictated by site-specific protocols. And I know it's really difficult to speak generally about this, but I think you've really done a good job communicating this. And I know I have a lot to learn. I think our listeners will as well.
Thank you so much for the opportunity. I mean, ECMO anticoagulation is my passion, so I think I could talk about it for hours and hours, but I understand everyone isn't as invested in the clotting cascade, but hopefully this was helpful to try to elucidate a little bit about each of the tests and different agents and when to think about when to use some tests and agents versus others.
Oh, for sure. And thanks to you, Lisa.
Yes, thanks, Zach and Alex, for having us.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.